So basically, about Synergy Life Solutions, we have been known for we did for the vacuum therapy devices because we launched in Sri Lanka about 10 years back, the first time. So I'm not going to talk about vacuum therapy because now we have completed 25,000 plus installations. So it can be used and it's commonly used now for trauma and various diabetic and vascular diseases and pressure ulcers, venous, and those things. So today, I think since the program also is on the wound care, I think they'll be covering more on the negative pressure wound therapy. I'm just running through what we have been doing so far on the vacuum therapy. But our main purpose, I wanted to introduce what we have been doing other than wound care. That is our prosthetic division. So in the prosthetic division, we have been manufacturing mechanical and robotic prosthetics in Sri Lanka. So today we have this month we have launched a new bionic hand. So I want to share some details about the new bionic hand that we have launched. So basically, bionic hand sound is a kind of bionic hand means like it gives more human-like functions, and you don't need any like special attachments. So it will work give you more freedom to work, freedom to active, and you can do almost all functions. And this advantage of compared to bionic hands, what is currently in the market, this response time is much faster, and we have a faster response time, and those suffered the amputation, they don't need to compromise on the activities. Few advantages of the new hand is so this has the heaviest, most gripping, strongest bionic hand because it's the most gripping strength it has. So it can you can do up to 35 kbs, kilograms, and impact resistance. So it can be you can use in the heavy duty work, and it has a for delegate it has a function where you can program when you're doing the software, and depending on the person's requirement like occupation, you can choose like it is camera on or like doing the homework, so you can easily program. And most important thing about this is we have the facility to the for the repairs. So repairs and the support can be given remotely. Patient doesn't have to come to our center, so he can log in into his mobile or the laptop, and we can do the programming remotely. So even patient is from our outstation, and in repairs and everything can be done remotely. I'm just showing a small how we are doing it. Here we can get the patient information, what type of work he's doing, what type of activities, and we can customized program and as per his requirements. So basically, I want to introduce Bionic Hands. It's the latest version and is relatively economical also. Like we have this hand available at 6 million, and we have the emotion which is available at 4 million. So I think it's more affordable to most and the advantages to those people to become more active. And in addition to that, we have our silicon lab. So in our silicon lab, what we do is we do the custom cosmetic prosthetics. So we can customize as per the patient's requirement. Like few examples, like if like this amputation, so we do manufacture something like this, which is customized, and the color and everything will be similar to the his previous hand. And depending on his requirement, they are customized. And we have our own silicon lab in Sri Lanka. So, and in addition to our current lower limb portfolio, these are the new additions I wanted to introduce. And I want to, depending since there's a limited time, I'd like to conclude this. And if any further information is required, we have our staff and representatives outside. We are pleased to give any information. Thank you very much.
Yeah, thank you very much. So we'll move on to today's lecture. So welcome you again. I welcome you again to the monthly clinical lecture series organized by the Doctors Welfare Society of LRH. And I believe this is the first topic related to the surgery during this lecture series. And today today is our sixth installment of the monthly clinical lecture series. So today's topic is understanding wound management, essential guidelines and best practices. It should be delivered by Dr. Pragaash Shanmuganathan, consultant in plastic and reconstructive surgery in LRH. Yes, sir. Over to you to conduct your time lecture. Thank you.
Good morning. I'm Pragaash Shanmuganathan, plastic surgeon. Currently, I work in National Hospital Kandy. Unfortunately, I had to leave LRH, at least temporarily. Today, we'll talk about wound management. I wanted to talk about the wound management not for the plastic surgery trainees or advanced surgeons. This is to suit the audience, younger doctors, general practitioners who do PP, surgical doctors. So it will be helpful for the people who want to understand and how to manage the wound successfully. So the primary goal of any wound care is not just giving a technical expertise or just suture in the wound. So apart from that, you have to provide an optimal condition for the wound to heal. So we will facilitate the natural process to go on. Sometimes some wounds may be complex, so it's preferable if you can get opinion or advice from a plastic surgical team. So we'll be happy to advise over the phone, or we can share the photos and get opinion. So the goals for any wound care is first to achieve hemostasis. So this you can achieve with various forms, and then at the same time you have to decrease the tissue loss, and then you have to promote the wound healing. At the same time, minimize the scar formation. The healing of wounds is by three mechanisms. One is by primary intention. Here where you suture the wound. The wounds which are less than 24 hours old, that's a clean and viable tissue. And then these wounds will epithelialize within 48 hours. So in fact, you can ask the patient to take a bath or shower after second or third day after suturing. The next mechanism is by secondary intention, where you leave the wound open to let it heal by itself. Usually we do this for some contaminated wounds, sometimes in some small cuts, some of the burn injuries. Here the healing occurs by the natural processes with re-epithelialization, and then there will be wound contraction by myofibroblasts. The issue with this kind of healing, there will be a scar, and then there will be a scar contraction as well. The next mechanism, healing by tertiary intention. This you delay the primary suture for 3 to 4 days. Sometimes you get a wound that's heavily contaminated, the contaminated with sewage or maybe some bad animal bites. So these wounds you can initially wash and debride, keep it for 2-3 days, and then when you're happy, the wounds are clean, then you can suture, and from that point onwards, it will behave as a wound that healing from primary intention. The scar will be little minimal. At the same time, you have to consider the factors that affect the healing as well. There can be wound factors and patient factors. So the commonest things that interfere with wound healing are diabetes, infection, people on steroid and chemotherapy, and poor nutrition, vitamin deficiencies, and people on radiotherapy, peripheral vascular disease, and anemia. And then if someone stitches the wound under tension with tightly, that can cause local ischemia. And then in a patient with a polytrauma, like a major burn, like intra-abdominal injuries, RTA, they can have a poor healing. So whenever you see a patient in the emergency department, your BP from surgical wards, always try to get history properly, identify the mechanism, how it happened, sharp injury, blunt injury, blast injuries, or is it a burn, what time it happened, and what is the environment, whether he's working in the sewage, or any chances of foreign bodies, whether it is a bite wound, and if it bite, what kind of an animal. Then on top of that, you ask patients medical problems like allergies, any medication like diabetes, and then you ask about the tetanus immunization status, and then also what time the patient ate or drank might be useful for the anesthesia. So some facts about the animal bites. These we consider as wounds that are at high risk of infection because it's a heavily contaminated wound. These bite wounds are mainly polymicrobial, and then at the same time, they can also have underlying nerve, tendon, or vascular injuries. So animal and human bites, primary closure, we consider in selected wounds. So when we are confident when there is a lower risk of infection, and if you are confident that wound can be adequately cleaned and washed, then we can suture the dog bite or animal bite primarily. You don't have to put it for 24 hours or 48 hours. The earlier practice was to delay the suture for 3 to 4 days, but the current recommendation, there is no difference between the infection rate. If at all, there's a better cosmetic outcome if you suture it earlier. So this is for selected wounds, not for the large wounds with the loss of limbs or anything like that. But on the facial wounds, the smaller laceration, you can suture immediately. So we commonest antibiotics that are recommended augmentin, chlormexiclav you can give as sensitive to the most of the organisms from this animal's mouth. And then if the infection is serious, you can go for ceftriaxone or piperacillin. All these patients should be vaccinated for tetanus. For the rabies prophylaxis, there are different guidelines given at different times by the virologists. So you have to talk to your virologist and ask what is the latest recommendation. So that tend to change over time. Sometimes they say you have to vaccinate only. Sometimes you have to give the serum also. So always get the opinion from the microbiologist. So if you look at the dog bites, there can be dog, cat, and monkeys and human. So all polymicrobials. Out of all, the most serious bite is the human bite. Because it's more pathogenic to the other human, and also we harbor more than 6,200 different kind of organisms in human mouth. So compared to the animal bites, they have to treat human bites little vigorously. So then after your history, then you do examination, then look for the extent of tissue injury, look for the degree of contamination, and then if you have any doubt about the injury to the underlying structures. So examination, you check the body location, see if there's any closer by critical structure that can be injured, like nerve, tendons, or blood vessels. and then you can examine and see if the patient has any deficits. So this will be important for the nerves. You can ask the patient to move and test the sensation. If you are worried about the vascular injury, you can check the color, capillary fill or saturation. So examination, wound location, sometimes it's important. Some of the wounds that occur in places like axilla, groin, perineum that has high potential for infection. But some areas like face and scalp, because there's a very good vascularity, these wounds tend to heal better compared to the other areas, and the risk of infections are also less, however much the wound is contaminated. And then you get a patient, you get the history, and then you examine. Then sometimes it's difficult to examine when the patient is in pain. So you can use a local anesthetic, your emergency department or in wards. You can infiltrate the wound, and then you can wash the wound at the same time and examine, see if there's any underlying injuries. If there's no underlying injuries, you can stitch the wound wherever you are. Otherwise, you can repair accordingly. So everyone who does use the local should know how the safe dose of the local anesthesia. So the easy way to remember is the plain lidocaine is 3 milligram per kilogram, and with adrenaline is 7 milligram per kilogram. So you multiply that and divide by 20. So that much of milliliter you can give safely. If you want more volume, you can dilute with some saline or distilled water. Bupivacaine marcaine, so be a little careful when you are using out of the hospital situation, like in the general practice like that, because some of the patient can get complication like arrhythmias, then might be difficult to manage. So using a local with adrenaline like epinephrine is little advantageous, it will increase the duration of the local anesthetic and also help with the hemostasis, so it will be less bleeding. So it will be helpful to the suturing or washing. So the patient might feel a little pain when you inject with adrenaline solution because it has little pH, but as soon as the lidocaine kicks in, that it will go numb. There are some views about avoid this adrenaline at the end arterial areas like ear, tip of the nose, fingertips, and for penile box. That's also a controversial topic. For your purpose, you can avoid those areas. For people like plastic surgeons and some of the vascular people, and then other surgeon might use it in these areas, because there have been some reports saying it can be safely used even if there's an arterial area. But for your purpose, just avoid it in these parts. So hemostasis, if you get a wound that is spotting, bleeding, and then you don't know what's happening. So first thing, do not panic. Just elevate the limb, take a bunch of gauze and put pressure, and then keep it for 5 minutes. So keep it for 5 minutes. Don't take it out. Just wait, and it usually stops. And if you are not happy, then you can use some bandages on top. Or if it's a major bleeding, like a major trauma, patient is collapsing, it's a major limb bleeding, you can use a temporary tourniquet. You can use a blood pressure cuff. You can use some many bandage like elastic bandages. If it's a oozing from any wound, you can take some adrenaline soaked gauze and just put it and wrap it up. If you have facilities where you are, you can use a diatomy or use some ligatures like a suture to ligate the blood vessels. But ligating is not always needed. As long as you put a proper bandage or elevate, it usually stops. So what will keep on bleeding is as long as you panic, it will keep on bleeding. To relax and you manage it properly, it will stop. So once you have stop the bleeding, then you can irrigate the wound and then make it clean, remove any foreign bodies if you can see. And if you think that patient is at risk of infection like animal bite, or patient came very late, then you can start on antibiotics. Patient on diabetes, if they have any implants inside, start on antibiotics. If you suspect any foreign bodies, sometimes you can First and see if the patient has a point tenderness. Sometimes you can do as X-ray. X-ray, you can see metal or glass or sand like that. Sometimes the organic substances like a wood and plastic is not visible. In that case, you might have to order an ultrasound scan. Wound washing, it's recommended you use at least 200 to 500 milliliter, like one bottle of saline to wash. You can use it with the drip set, or you can use a syringe. Take a syringe. Sure. Yes. So you can take a syringe, take a needle. You can break the needle from this point, and then you can use it like it will give a nice pressured irrigation. So it's one of the simple device setup. You can use it wherever you are. Then we used to dress the wound with betadine. So betadine is considered to be cytotoxic. It is just a skin antiseptic. It works on the well on the skin, but not on the soft tissue. So use it for cleaning your wound, but when you have to dress the wound, it's always better to avoid the betadine. And also, peroxide is also shown to impair wound healing because they interfere with the neutrophils and macrophages. So if you can avoid, it's better. If you want to use betadine, use it as an ointment, so it will be less toxic. Hair removal. Before surgery, to shave the patient is sent to theater. It's been shown like this patient, the infection risk is about 10 times higher. So now the recommendation is to instead of shaving, you clip the hair or trim the hair. If you do operation on the hair, you can use the Vaseline or some gel just to put it on the hair, so it will get matte and it will be away from your surgical field. Never shave the eyebrows because these are cosmetically important region. The eyebrow might not grow again. So there can be a legal issues if you shave it. Then you think about, look at your wound and see if it's a sharp wound, you can proceed for suturing. If you think it's a contused or contaminated wound, then you have to do a debridement. If your wound is like a rounded shape, it's difficult to close, then you can make it like as an ellipse, and it will be easy to closure. And if you're making an ellipse, then keep an just think about how will be the cosmetic outcome. So always try to, there's a thing called skin tension lines when there's a skin fall that wound heals with a lesser scar. So the way we debride is we trim about a millimeter or two of the skin from the edge of the bone. So basically you are converting a laceration into a surgical wound. So the healing will be better and the cosmetic outcome will be also better. Suturing. So always try, if you can put 2-layer sutures and you won't use a deep suture, deep layer. Always try to bury your knot under. So you can start from deep and then come out and then go deep and then put your knot here. So this will serve two purposes. This will close any potential spaces deep in the wound, so there will be less space for hematoma and any collection. And also it will reduce the tension. So whatever the skin suture you are going to use, you can use a smaller suture that will be better cosmetically. So suture point of view, your wound is not held by your suture. The suture will keep the edges approximated. So you don't have to put big sutures to bring your edges together. Always try to think about the smallest possible suture you can use. So whenever you put your deeper suture properly, you don't have to put a very thick sutures outside. So your cosmetic outcome will be better. Sometimes if you have a skin loss, then you might have to put a small skin graft on it. In that case, you have to refer the patient. Skin closure, so we recommend always try to get the wounds edged, everted. So our skin to skin, when it touches, it's not going to heal. So when you invert, the wound's not going to heal. As long as the soft tissues are in contact, that will heal. And then at the same time, the wound, there going to be edema after 24 hours. So when you put too much like strangulatory suture with the edema, there will be some more pressure. It can cause a little bit more tissue necrosis on the edges. You don't have to put too much tension on the wound. There are, other than suture, there are other devices you can use. Staplers, the other thing, these are very quick, but the downside is there's a poor cosmetic result. We also use them in areas like the scalp where there's this issue of scar. Gluing, histocril or dermabond. Sometimes parents want to know whether we can glue it or tape it and say. So we do use them in selected patients where the laceration is smaller, 1 or 2 centimeters, and there is no muscle action on the edges on the wound. So it's like a relaxed areas, you can use them safely. For our weather, because we sweat a lot, our skin is little oily. So if you put a strip, after a couple of days, it's tend to come out. So usually we get after a few days, the wound has opened up. So keep an eye. Sometimes, although we say it can be used for our skin and our weather, it might not be suitable. Suture removal on the face, you usually remove it like after 3 to 5 days. On the upper limb, about 7 days. The rest of the body, we tend to keep up to 10 to 14 days. So if you don't remove a suture, like in a specified days, then there is a chance you can get a bad scar. So if you don't want a bad scar, you can learn to suture some subcuticular suturing techniques or kind of like that. Any surgeons or even us, we are happy to train you if you want to come and watch how to do it. After you suture, then you would care the wound post-operatively. So we recommend keep the wound moistened for first couple of days. We can use some Vaseline or any ointment on the wound. This also helps with the reepithelialization. After the second days, the wounds tend to be watertight. So any wound, you close it, you can ask the patient to remove the outer plaster and take a shower after 48 hours. If you put a band, if you have a wound on the upper limb or lower limb, then you can put a small bandage like a soft screen. It will absorb whatever the fluid that's going to come out and will also protect the wound. Then you optimize your parameters like diabetes, advise the patient on glucose control, and then ask him on nutrition, vitamins, stop smoking. In some of the major wounds, we recommend patient to take some vitamins like vitamin C or zinc, so they will help with the wound healing. So reduce the edema, then ask them for elevation and compression bandage. Negative pressure wound therapy is mainly for surgical people to reduce the edema. Antibiotics so any patient who comes later, or if you think that the patient is at high risk of infection like animal bite, human bite, any environment like patient was working on sewage, then start antibiotics. Sometimes you can use the antibiotics topically. Some people tend to flush the wound with some antibiotics and use the antibiotic dressings. But the evidence is lacking, but the efficacy is also questionable. It's kind of a personal preference rather than research guided. But whatever said, you have to avoid using unnecessary antibiotics in any patient. So you don't have to create a multi-drug resistance. So always be judicious and careful about what antibiotic you use. Tetanus prophylaxis, you should know. It's a clean wound. If the patient is vaccinated less than 10 years, you don't have to give anything. or if it is incomplete vaccination or more than 10 years, then you do the topside. In the tetanus-prone wound, working in a paddy field or sewage, the patient is incompletely vaccinated, then you give the immunoglobulin as well. So we talk about the dressing. There are different types of dressing you can use. There are non-adherent dressings like Vaseline gauze. There are some padded dressings. So whenever you use the non-adherent dressing, you have to put a secondary dressing on top. Or you can use occlusive or semi-occlusive dressing. These are also over-the-counter dressing. So these are suitable for minimally exudative clean wounds that will also protect your wound from outside bacteria or water. Most of these dressings are waterproof, so you can advise the patient to bath even the next day. Although it's waterproof, it is permeable to the water vapor and oxygen. So the wound will get oxygenated and hydrated through the whatever the membrane, but it will not let the water to get in. So that's the advantage of using these dressings. So depending on the absorption, there are different types available. If the patient has a very high oozing wound, like a pressure wound, there are so many things you can use: hydrogels, hydrocolloids, and then there are on the market there are so many things with the newer dressing materials. They say they have the silver, and then iodosorbed nanocollagen, various things. So you can use as long as the patient can afford, or if you're happy with the outcome. So we don't recommend or not recommend to using it. It's your preference. Yeah. So basically, I just wanted to give an overview of wound care to all the people who work in the OPD, do general practice, emergency department. So we don't want to talk too much on the complex wound management. So there is specialized people for that. I hope that gives some basic idea onto how to manage a wound even at your home or your GP practice. Any questions? Happy to answer. And then thanks for the organizers the opportunity. Thank you very much.